Hello everyone, Dr. Sutter Caton, physical therapist here with Vive Health. I'm looking forward to sharing all my knowledge with you and I hope you enjoy. So as I talk about a hip impingement, it's important to first go over basic hip anatomy to get an idea of what's going on. So in the hip, you have the femur sitting inside the acetabulum, which is the socket of the pelvis that the bone sits in, sort of like this. So on the ends of both of these surfaces where the bones articulate, they're covered in cartilage that just shock absorbs, provides reduced friction, freedom of motion. Around this entire structure is what we call a labrum. And so you can think of it as sort of a loose bag that helps support the joint and attaches the bones to one another as well as other ligaments. So what happens with a hip impingement, you might have seen another video on shoulder impingement where it's a muscle being pinched. In the cases of a hip impingement, it's actually the cartilage or the labrum that is pinched by basically improper or premature contact between the bones as they go through normal hip motion. So if you have a hip impingement, the typical places you're going to experience pain are going to be the front or the front lateral side of the thigh, but you can also have pain radiate down the leg, it can radiate into the groin, it can even radiate towards the back and the SI joints. So it can be tricky from a self or even a professional's point of view to tease out where this pain is coming from, because someone may think it's a back problem when really it's your hip. So the positions that we find the pain to be worse in are going to be squatting or sitting or any activity where the hip or the knee comes to about 90 degrees, and then combining that with internal rotation is going to be a very painful motion for someone with a hip impingement to occur. That position just has kind of the most contact between the femur and the acetabulum that you can have in the joint. So if you experience an impingement, that position is typically going to be one that I'm going to try to put you in to see if I can reproduce your pain. You may also just have a sense of stiffness in the joint at all times, especially if you've been sitting for a long period of time. So if you're sitting at the computer or you've been driving for a while, that hip can be very stiff as you go then try to get up. In severe cases where there is a labral tear, so over time where that labrum is now torn, you can experience clicking or catching as basically that labrum is getting caught between the bones through certain motion. And so then you have a much bigger problem on your hands. So as we talk about risk factors for developing a hip impingement, I'm going to first discuss certain genetic variations that may predispose somebody to develop an impingement. So there's two types of what we call hip deformities that you can have. So there's a cam deformity, and that's where the head of the femur has just a little extra growth of bone or has extra bumps that otherwise make it not as congruent as it should be. And then you can have what we call a pincer deformity, and that's where the acetabulum, the rim of it, has a little bit more coverage and kind of hooks a little bit more so than usual. And so that also can cause an impingement. But most of the cases, people have both of these. So they have what we call a mixed type, and that really can predispose you to developing this. It's important to note that just because you have this bone growth or these deformities in your hip doesn't mean you are guaranteed to develop an impingement. It's just that someone with an impingement likely has these going on. So if you get an x-ray for other reasons and this shows up, don't get scared and think that you're going to develop a hip impingement, because it doesn't mean it's very likely. The other thing we look at is typically people who are involved in sports that require extremes of hip range of motion. So I might be looking at hockey players, figure skaters, gymnastics is another one. Basically anything where you're sort of pushing the boundary of that hip joint over and over again can develop this hip impingement over time. As far as diagnosing a hip impingement, from a PT's perspective, I'm gonna once again, like always, take a nice subjective history, get an idea of the patient reporting when the pain occurs, how long it's been going on for, what makes the pain worse, what makes it better, what sports or hobbies are they involved in. Then I'm going to assess their range of motion, their strength, the ability of the joint to move passively. There's certain special tests I can perform, as I mentioned before, with hip flexion and internal rotation can be provocative to a hip impingement. There's certain special tests, we call them, that put the hip in a certain position that if you have an impingement, I can basically reproduce your pain, which is what I want to do, so then I can determine this is a hip impingement, and then from therefore we know where to begin treating. From the physician or imaging or non-conservative side of treatment, your doctor may perform an x-ray, but like I mentioned, certain abnormalities may show up that aren't directly related to the pain you're experiencing. So it's important that any x-ray be matched with symptoms. And it's important hip impingement doesn't occur just as you're standing normally. It only occurs during motion, which x-rays don't capture. They may also perform an MRI, and that's going to give us an idea of if there is labral or damage to the cartilage that we may then want to go the surgical route to alleviate. As far as treating a hip impingement, from the PT side of things, I'm going to first try to find a way to teach you to avoid the activities that cause the pain, see if we can't minimize sitting or driving or any static position for too long a period of time. I'm going to perform stretching, I'm going to perform manual mobilizations where I physically, manually move the femur during movement to allow normal movement to take place, and see if we can't retrain your brain to move that limb without experiencing pain, because if you've been in pain for a long period of time, you basically have learned to expect it. So I've learned to expect as I move my hip up, as I go into a squat, I'm going to have pain. And so we need to try to break that cycle. And so typically that's with hands-on work to get you through those motions without pain. I'm also going to strengthen areas identified as being weak. So this might be the hip abductors, this might be the glutes, this might be some other muscles involved that are contributing to the problem. I'm also going to look at your form during exercises. So if you're someone active and you tell me, I'm only experiencing this issue when I'm doing my squats with weight, I'm gonna assess your squat, because it might just be an issue as you squat down, say we let that hip fall into too much internal rotation or some other sort of abnormal movement of the hip as you go into the squat. If it's as easy as retraining you, as cueing you properly to perform your exercises better, then that's a nice, easy way to avoid having to spend more money on seeing more specialists. It's just a quick, easy way to alleviate what the provocative exercise is. On the more non-conservative, the more physician side of treatment, they may look at an arthroscopic surgery to clean up the areas of the bone that are impinging. So they might look at clearing up either the cam or the pincher deformity that I mentioned before. In cases of a labral tear, if you're young, they're gonna probably try to go in and repair that labral tear. If you're older and there's typically gonna be arthritis involved, you're gonna have more substantial labral tear, even more pain. They may avoid both of those and just go straight to a hip replacement, as the outcomes are gonna be better than that. If you're already 60, 70 years old, that just is a better option than trying to do a labral repair. I hope you found the video helpful, and thank you for watching.